I like your picture.
Thank you.
Okay. Good morning. This is take 2, and it's raining and not snowing, so we're in good shape. This morning's session is Transference and Countertransference by Dr. Klafter. Before I do the biographical presentation about who Dr. Klafter is, some technical things. First of all, please, cell phones off. Okay, we're all therapists. If you're going to have an emergency, put it on vibrate, do whatever you can, please. It's really disturbing if it's on. For CEUs, there are 2 sign-in sheets on, there's actually 4 sign-in sheets on those 2 back chairs. Somebody put a nefesh bag on top of one of them. Because this is a double session, you need to sign in and out twice. So you'll get credit for both parts of the session. Towards the end, about 5 minutes before the end, Dr. Klafter will hopefully stop and give out evaluation forms. Please take the time to fill them out because they're useful for nefesh and for programming. If Dr. Klafter is not here to collect them, you can give them into where you signed in to either Joe or to Alice, just so we have them, please. If you're going to ask a question, I've asked Dr. Klafter to please remember to try to repeat it, but if he doesn't, somebody please remind him, if I'm not here, to please repeat it, because otherwise it doesn't come out in the recording, and it's very, very frustrating. I think that's all in terms of technicalities. Okay, this presentation, which I'm sure many of you have been looking forward to, is going to be given to Dr. Klafter. Dr. Klafter is a director of psychotherapy training at the University of Cincinnati Psychiatric Residency Training Program. He received his MD from State University of New York at Buffalo, completed his specialty training in psychiatry at Thomas Jefferson University Hospital in Philadelphia, where he also served as chief resident. Dr. Klafter remains a private practice in psychoanalysis, psychotherapy, and general psychiatry and psychotherapy supervision. Dr. Klafter joined us for the second time today from Cincinnati, Ohio, where he lives with his wife and 4 daughters. And so we welcome and look forward to Dr. Klafter's presentation.
Good morning, everybody. Anyone that's confused, no, it's not Monday, December 27th. That was, I didn't notice that till just now. It's not Chav Tevis either. So that is my office. So this is the order of the presentation today. We're going to do an overview of psychodynamic psychotherapies, not to spend a huge amount of time on just reviewing theory, but to talk about theory just from a very practical point of view, which is how to think about transference and countertransference in light of different approaches to psychotherapy. For those who are very familiar with psychodynamic theories, I hope this will be something still new for you. And those who have not had a lot of training in this, I think that it will be very understandable. I'm a pretty simple person. I try to make theories practical and useful. We'll talk about the central role of transference and countertransference in psychodynamic psychotherapy. It is probably the main thing that distinguishes psychodynamic therapies from other forms of therapies. We'll talk about differing conceptions of transference and countertransference. We'll talk about some of the stigma and controversy with countertransference, how to use transference and countertransference in clinical technique, and we'll do all of that in 45 to 60 minutes, and then we'll take a break and we'll have a workshop where I'll be asking probably 2 sets of 2 people each to volunteer. I'll ask one of you to portray, 2 of you I'll ask to portray a patient that you have treated who has stirred up a lot of powerful feelings in you. So you can start to think about that now, anyone who's brave. And then I'll ask others to portray a therapist trying to treat that patient. So we'll do that workshop format at the end. And I'll interrupt you quite a bit to talk about things in terms of the transference and countertransference. And then question and answer. In other words, your ideas and comments. That's usually what questions and answers are. I don't mind being interrupted at all. Some people like to have all questions at the end of a presentation. I actually am happy to have questions during the presentation. If I think that it's too long and we have to move on, I'll do that myself. So don't worry. Feel free to interrupt me. I actually enjoy that during a talk. was going to talk a little bit about what I do. I think she covered most of this in the introduction, but I spend 2/3 of my time in private practice where I do general psychiatry, psychotherapy, and psychoanalysis, and also psychotherapy supervision. And I spend about 1/3 of my time teaching psychotherapy. Being the director of this program, I develop curriculum for psychotherapy. I give lecture series on theory and technique of psychotherapy, and also supervise residents. So that's how my week is divided up. I'll start with this, which I like to start with a cartoon. But this one really says it all. This really says most of the presentation. So the patient is saying, and I haven't met anyone interesting in years, complaining about how boring and unhappy his life is. And the therapist is thinking, well, what about me? What am I, chopped liver? What do you mean you haven't met anyone interesting in years? So I think that this cartoon sort of says it all, which is that while patients are talking, patients say things that affect us. We have emotional reactions to our patients. We're often, I think, reluctant to acknowledge that our patients can hurt our feelings, that our patients can gratify us, that when our patients are grateful or attracted to us, it is flattering, it does feel good, it is scary. I think that we like to cultivate a very cool attitude and say, oh, yeah, this patient loves me so much, I'm just waiting now for the patient to split on me and then hate me. It's actually not true. We say that because it's actually very powerful. When a patient is very grateful or very affectionate to us, it has a deep impact on us. When a patient is mad at us and feels hurt by us, we feel hurt. It isn't true that we're just cool or neutral to what goes on with our patients. It's sometimes scary or painful to admit that, but it can also be the most powerful clinical tool that you have is to pay attention to your feelings. So I think this is a good therapist or a good analyst who notices that this is insulting. It's insulting for the patient to say, not that I recommend saying, hey, how dare you insult me? That's not the intervention I'm recommending, but that therapist should notice that the patient has said something insulting to the therapist. It's probably important. So transference, a little bit about what transference is. Let's see. This looks like a slide that we just went through. I'm going to do a case presentation. Adam is there are going to be a lot of case illustrations because I think cases are the easiest way to illustrate things. Adam is a 33-year-old man. He's single. He works as a statistician. And his presenting symptoms are depression and that he's still in love. I'm still in love with the woman who dumped me, he says. He was engaged, but his fiancée announced that she was having an affair with her boss and that she's fallen in love with him. His boss left his wife and invited her to move in with him. So Adam is basically been dumped during his engagement. They had already sent out wedding invitations. It was a very humiliating experience for him. He says, I could see she was much happier with him. I know him. He's much more exciting than I am. He's better looking. He's more successful. I'm too boring, and people barely notice me. That's what Adam says about himself. Adam feels that it's highly unlikely he will meet someone who will fall in love with him. So this is Adam's kind of presenting. This is the overall picture in the first several sessions that Adam presents about himself. He doesn't immediately say that he's boring and that he can see that she's happier with him, but that comes out in not too long, maybe over a few weeks, he can express that. So with this case in mind, I want to talk a little bit about the dynamic unconscious. Why do we use the word dynamic, by the way? What does dynamic mean in terms of psychodynamic theory or psychodynamic psychotherapies? All of you use the word 1,000 times at least. But what does the word dynamic mean? And no one knows what it means. It's a funny term. It means motivations. The dynamics of a situation are what people's motivations are. If you're in a group and we say, what are the dynamics of this group? It means, what are each of the people in the group trying to accomplish or afraid of or trying to do? What is their objective with one another? And the deep objective that they may be unaware of themselves. So psychodynamic psychotherapies or psychodynamic theories are theories of human motivation. And one of the assumptions is that human motivation is largely unconscious, that there are many wishes that we have, some of our deepest longings and needs and wishes we're not aware of on a moment-to-moment basis. We might be able to be aware of some of them if we stop and think about them, but they're not on our mind from moment to moment. They're residing and influencing us from an area that's outside of our awareness. And there are various sources of motivation. These motivations are in conflict with one another. In terms of Adam, Adam has a wish to find a new partner, a wish to find a new lover, a girlfriend, a fiancé, to be married and have a family. And he's also deeply afraid of rejection. Those are two motivations inside of Adam. They seem fairly obvious to us when we listen to him. But strangely, Adam has convinced himself he's not really interested in seeing somebody new. He's going to focus on his job, and he's going to focus on hobbies, and he's going to work out and get in shape, and maybe he's better off being a bachelor. That's how Adam would sort of think about it. Now, when we say these motivations are in conflict with each other, the wish to find a partner is in conflict with the fear of rejection. I mean, it's easy to see that. If you want a new partner, you have to flirt, you have to put your name out there, you have to be open to solicitations by the helpful people in shul that want to set you up on a shidduch. And that stirs up a fear of humiliation. This conflict produces distress. If I think of flirting with this person that I'm attracted to, there will be a fantasy of being rejected or humiliated. That is distressing. So one of the major tasks of the human mind is to try to minimize the distress that results from these conflicts. That's what the mind does for us. So what he tends to do is he will disavow his attraction to other women. He will not notice that he's attracted to someone. He will not think about it in that way. So according to this approach to the mind, psychological symptoms and stunted development are attempts by the mind to minimize distress. That's what's happening. I'm trying to avoid feeling distress. And as a result, my symptoms are signs that I'm trying to produce distress. Another way to say it would be, symptoms are unsuccessful or partially successful attempts by the mind at self-healing. So in this case, if I have a fantasy of being rejected and I feel humiliated as I start to spin that fantasy out in my mind, I can avoid distress from that feeling of humiliation, but I'll have to do that by sort of taking women off of my radar screen, and I'll remain alone. So it's sort of, that's the cost of, and that's how he's attempting to heal himself. So I think one of the first things to try to do, according to this theory, is when people talk about self-sabotage. Yes, it's self-sabotaging for Adam if his objective is to be with someone. But we get confused and we start to talk about it as though Adam wants to sabotage himself, like he has a wish to sabotage his development. He has absolutely no wish to sabotage his development. He wishes to avoid feeling humiliated. He deeply wants to move on in life, and he's in a lot of pain over not moving on in life. He doesn't want to sabotage himself. So I think one of the ways to be helpful is to see symptoms as an attempt. It's not a good attempt, it's not a successful attempt, but it's an attempt at self-healing. Just put a little bit of Torah into this. This is a Mishnah that everyone here probably knows by heart. Yeshua ben Parachia Omer, Aseh lecha Rav, Uknei lecha Chaver, v'havidanis kol adam l'kaf zchus. That Yeshua ben Parachia says you should fashion for yourself a teacher or a rabbi or a mentor, cultivate for yourself a teacher or mentor. You should acquire for yourself a friend, and you should judge every person favorably. So the Sfas Emes on this Mishnah says something that I think is very important about psychodynamic theory. He says the words don't make sense. Havidanis kol ha'adam l'kaf zchus. What does that actually mean? It doesn't mean literally, if you think about it, anyone here that knows Hebrew well, how would you actually translate that? If we wanted to say judge every person favorably, it would be dan kol adam l'kaf zchut. It would not be dan es kol ha'adam l'kaf zchus. Es kol ha'adam l'kaf zchus means that we should judge the entire person favorably. It's not every person, it's the whole person. So that's what the Sfas Emes points out. Try to judge the whole person favorably. Okay, so in psychodynamic psychotherapy, that's what we try to do. We try to see someone's self-sabotaging symptom as an attempt at healing. Okay, that's an attempt at helping himself. It's not an attempt to sabotage himself. So the word, I have like sort of a bias in supervision. Sabotage is a word that is not helpful. I think it is not a helpful way to understand it. He's trying to help himself. That's why he's doing this. Okay, so there's another case example, symptoms as attempts at self-healing. Okay, this is a true case. Roberta was, at the time, a 25-year-old graduate student in electrical engineering, and she developed chronic fatigue syndrome and fibromyalgia. By the way, I should have said this before. I change my cases in a way. I mean, I truly believe it would be completely unrecognizable for any of you to recognize any of these cases. So if you think, oh, I know who that is, you really probably don't. It is a small world, and I have no idea if I've treated someone in another city who went to someone else for therapy and might have told you that I was a former therapist. So if you know, if I'm wrong and I failed to disguise a case, I'll use your judgment as to whether it's fine for you to be in this seminar. But these cases are very highly disguised. I think it's impossible you could recognize someone. So her symptoms are chronic fatigue syndrome and fibromyalgia. And she has seen numerous experts in fibromyalgia. She's achieved some relief, but her condition continues to interfere with her ability to attend class, teach, and conduct her research. She becomes profoundly depressed. And she's not going to lectures. She's not going to the lab. She's really failing to make progress in her PhD program. I prescribe an antidepressant for her, and she suspects that I, quote, do not believe in the validity of chronic fatigue syndrome or fibromyalgia. You think it's all psychological. Okay, she is right, but I don't think she should have known that. During psychotherapy treatment, she reveals her belief that her father, who's also an electrical engineer, will be deeply disappointed in her if she does not become a highly accomplished scientist. She also reveals how much she dislikes graduate school. She expresses a wish to drop out of graduate school and to pursue a career as a high school science teacher. As she starts to get this new career in mind, she no longer has any chronic fatigue syndrome or fibromyalgia. Those symptoms are gone. The antidepressant really didn't do very much. The freedom to pursue another career, she no longer had the symptom. So how would people here understand that? I mean, how do people understand that resolution of her symptom? It took a while for her to be able to acknowledge this. This was not just like an easy thing for her to go through. She found it very difficult and painful to acknowledge that she, in fact, does not want to pursue this career, that there's been so much hope and pride in the family, especially from her father, invested in her to do this. So how would people understand, why would that symptom resolve when she now wishes to pursue a different career and she feels the freedom to drop out of her graduate program? Any thoughts about that? Yes. So the comment is she's invested in approval from other people, her father, for example, her graduate advisor, and when she can turn to her own wishes, she no longer has the same need for approval by others. Is that the...
Yeah, and she's more attuned to her own approval herself.
Any other thoughts about that? Yes?
She doesn't need the chronic fatigue as an excuse anymore to justify why she doesn't do well. She's very disappointed.
She doesn't need the chronic fatigue as a symptom anymore. I think what you mean by that would be that the chronic fatigue syndrome was allowing her...
Excuse herself for failing her father.
Right. She could both be a heroic graduate student trying to attend, doing everything she can despite her illness to attend graduate school, and not be going to graduate school at the same time. Sort of provided a compromise. I mean, I think both of you are right in the sense that she was in great pain over the prospect of losing her father's approval of this, and I think the symptom did function in the way that you're saying. Yes? I agree with that. Suppressed emotions come out in other ways, and including physically, and I agree with you, and I think we're discussing just the particular way this suppressed emotion came out in her physically. That do you want to say something else about that, though?
Very often, there's a whole theory of back pain that once you acknowledge your anger, the pain disappears.
Right, that anger, suppressed anger, can come out as back pain or neck pain. What's the name of this book by this? Yes, this. I have everyone in my community asking me to read the book by Dr. Sarno and tell me if it's okay, in my spare time to read the book. So just do me a favor, read this 300-page book for me. Tell me if it's okay. Yes.
You'll have to make it as a comment, not a So the David Burns book, right? Big guy, wrote Feeling Good, everybody knows. He wrote a new book on anxiety, okay? And I gotta tell you, there's a split on the listserv, right? CBT, so different from psychodynamic. So one of his core theories that he discusses, right, of anxiety and panic in this book
Are based on the unconscious, right?
repressed emotions and how they come out in other ways. So, for everybody who reads the listserv and sees this big split, these things start looking real different, real similar, functionally, even though they sound so different.
Okay, so just for the tape, I appreciate the comment that there are CBT conceptualizations in contemporary books by, one of the classic teachers, David Burns, that there's not such a split necessarily between dynamic psychotherapy and CBT. I agree with you. That's a different talk that I've given before, but that's, those who know me, that is my perspective, that the differences between CBT and dynamic psychotherapy are largely artificial to some degree, and what people are actually doing is a lot more similar than the theory would lead us to believe. So we now understand her fibromyalgia as a way of both avoiding graduate school and making a heroic attempt at continuing graduate school in order to avoid disappointing her father, which really, I think, captures all three comments. This is a disavowed emotion that comes out as a symptom. It's approval of another person that she's now more free of, and it's a compromise formation with a symptom that was being used to avoid a conflict. She's now working through the conflict. The symptom doesn't have the same usefulness for her anymore. So let me ask you this question. How do we understand her experience of me prescribing an antidepressant as being an accusation that her chronic fatigue and fibromyalgia are not real? How do we understand that? Yes.
Well, she was very invested in feeling that her symptoms, her physical symptoms, were real symptoms, and when you gave her an antidepressant, you were kind of denying the reality she was at that point having to hold on to.
And why did she see that as me? I mean, she was depressed, though. She would agree she had all symptoms of depression as well. Why would she see that as me telling her, I don't really believe that these symptoms are real?
Because she felt that she was depressed because of her chronic fatigue and fibromyalgia, not that the other way around, that the depression was really from a different source, and that the other source, the unconscious source, was causing the symptoms, and she wasn't ready to accept that.
Okay, so she just saw seeing symptoms as due to depression in its own right, and being amenable to treatment for depression. She saw that as a rejection of her formulation of her problems. Some other thoughts about that? Yes.
I'm wondering if maybe she looked at you as, because you just gave her the medication, as somebody who was also just rejecting her and the way she was really feeling, almost like her father or whoever it was that was supposed to acknowledge her.
She may have seen me as her father in terms of having a rejecting or condemning sort of attitude toward her. Any other thoughts about that? Yes.
Well, I had two thoughts. The first is that since you're a physician, she might have hoped that you would refer her to a specialist who would target the physical illnesses she purported to have instead of steering her towards an antidepressant. You might, and the second thing that I've experienced with some of my clients who somatize is that even though they might disavow it, on some level they've also entertained the idea that it might be what they might call psychosomatic, or they might have a psychological root. And even though they prefer to think of it as physical, but I've had a few clients who eventually confided that they have also been grappling with that possibility.
Okay, so I think that's a similar comment, that it's sort of a threat or rejection or challenge to her formulation. I want to call on this very patient woman sitting right here who's raised her hands for every question so far.
No, I was thinking along the lines that there must have been a part of this young woman who really believed that there was a connection between why she was depressed and why she was feeling these symptoms and why she didn't want to go to graduate school anymore, but that she couldn't put it all together, and that somehow you were perhaps opening that door of saying maybe, even though I'm not sure if you said anything about her depression being linked to her fibromyalgia, but that by giving her the you were somehow potentially opening the door to making those connections, and that was really frightening to her, and she had to say, no way, you know.
So if your comment is some part of her does, in fact, is skeptical about the legitimacy of fibromyalgia and wonders if there is an emotional problem with her proceeding through graduate school, and my prescribing an antidepressant is sort of pushing a raw nerve that she's trying to keep off of her mind. That's your comment. So I'm going to move on, or else you guys are going to anticipate too many of my new slides. So we're going to talk a little bit about ego psychology. We're going to talk about 4 different approaches quickly to dynamic psychotherapy. Ego psychology is a model of how the mind works. This is sort of the classical psychoanalytic perspective on human motivation, which the tenets of this approach are that the human being seeks pleasure. And there are 2 main forms of pleasure, which are sex and power. Power might also be called aggression. Sex is sometimes called libido. But that these are the 2 main sources of pleasure, and that the human being is motivated by seeking pleasure. And the human being experiences anxiety, guilt, or shame when the pursuit of pleasure poses risks, or when pursuing that pleasure will be seen in a negative light by others, or violates one's own sense of right and wrong. If I will feel like an immoral person or a bad person because of my fantasy, which is to pursue power or money or an illicit relationship, that will produce anxiety, guilt, or shame inside of me. There's a great emphasis on understanding in a nuanced detail why the patient is unable to acknowledge these wishes, needs, or feelings. That's sort of what the therapy tends to be about from an ego psychology perspective. The therapist or analyst becomes a screen on which the patient can project any disavowed mental content. So the example is, you think that there's no such thing as fibromyalgia and that I just don't want to do this research. That's what the patient says. You see why I can't call on you that much more frequently. It's going to kill my presentation. So that the patient has this thought in her mind. She doesn't want to think about this. This would be a challenge to her integrity, and she's projecting this thought onto me right now in therapy. That would be a classical view of transference. Her wishes are projected onto me, or her thoughts or beliefs are projected onto me. You think that I just need to suck it up and get my research done, okay? That would be another example of something, that's a view that she has toward herself that she is putting onto me. You think I need to quit graduate school and pursue something that will make me happier. So these are 3 different things going on inside of her. They're all uncomfortable for her to feel, but you can see, it's quite plausible. We all have situations like this where I could easily attribute numerous things to someone else that are contradictory to one another. And these would be ways that she's experiencing me talking to her during the therapy. She certainly had all these views about me during therapy. Object relations theories are another approach to psychodynamic theory. It is based on a different fundamental belief that the fundamental motivation of the human being is not the pursuit of pleasure. That's not what people are trying to do. That's not what the fundamental drive is in the human being. The fundamental drive is to engage in intimate relationships with other people. So the person experiences distress over the anticipation of loss and loneliness when relationships are threatened. It's not about shame or guilt. It's about loneliness and loss. And that's fundamentally what bothers someone. Aggression and sex are important in object relations theory, not because they're the primary motivator, but because they're currency. Sexual intimacy is a way of expressing and feeling a deep, close connection to someone. Aggression is a way of experiencing or expressing a rejection of someone. That's why sex and aggression are powerful. But there are many other forms of expression that can be, a very powerful way of experiencing closeness or distance from someone, according to this theory. The person develops characteristic ways of relating to others and an affinity towards certain personality types, or a tendency to engage in certain roles. We see sort of so Freud described what he called the transference template. the transference template for Freud was that, inside each of us, we have a certain, I don't know if anyone here studied imago therapy, but imago, Freud's first journal was called Imago. Imago therapy is based actually on the notion of the transference template. But the transference template is sort of the characteristic way that I tend to experience other people. I've got my issues. Let's say that I like to, if I enjoy people laughing at my jokes, I will enjoy people who enjoy my sense of humor. That's who I'll gravitate to. When people don't enjoy my sense of humor, if they don't laugh at my joke, I don't like those people. Or I might try very hard to make that person laugh. I might have but that will be sort of like a shtick that I have that will show itself up over and over again. There are some people that are very into their personal appearance and how beautiful they look. There are some people that are very into helping and doing chesed for other people. We all have different things that we do sort of over and over again, and the way an object relations analyst or therapist might look at that would be that this is sort of the way that I have gone about trying to cultivate certain types of intimate relationships. There's a very important scientific measurement that was developed by Lester Laborsky at the University of Pennsylvania. It's called the CCRT, or the Core Conflictual Relationship Theme, and it's a scientifically validated way of measuring and describing people's characteristic relationship episodes. I won't go into that in detail here, but it's a very important contribution to psychotherapy research. So an example of thinking about Roberta's transferences according to object relations theories, Roberta begins attending synagogue. I wear my yarmulke in therapy, and she's Jewish, was not raised as an observant Jew, that was not a big part of her life, and it's the first time during all of graduate school that she started to do that. So this is something that she started doing during the therapy. Example 2, I offer an interpretation of a dream she has, and in this dream, my sense is that this dream represents wishes that she's been unaware of. And she experiences my interpretation as a criticism of her inability to acknowledge what's happening inside of her. So I see this dream as representing something happening inside of her she doesn't know about or doesn't want to know about, and she feels like I'm criticizing her. You should be more open. You should be more aware of what's happening inside of you. Those are ways that she would characteristically respond to many other people. She tries to please people by doing things that they're interested in, and she's very sensitive to seeing people's sort of dissatisfaction with her. So she senses that I value self-knowledge, and an interpretation that would describe her as lacking self-knowledge or having a limitation in her self-knowledge, she experiences it as a criticism. In terms of pursuing the same career as her father, we did absolutely talk about, countless very painful experiences in childhood where her father was very aloof, very busy, very uninvolved with her, and she found a way to get her father's interest, which was to become an exceptional science student, and her father was her tutor for physics, for calculus, for engineering in college. So her cultivating something that she realized is an interest to me, again, this is her characteristic way of relating to people. So the transference is not just a projection of disavowed content onto me. The transference is just another manifestation, as in life, of her characteristic ways of connecting with and relating to people. That would be how we see the transference according to this perspective. Self-psychology, which is another school of psychodynamic theories. In this theory, the fundamental motivation in the human being is the cultivation of a positive sense of self. Okay, the term narcissism, according to self-psychology, narcissism is a normal, universal, ubiquitous, necessary phenomenon in every human being. It's any mental activity or anything we do to try to cultivate a positive sense of self and to try to avoid a negative sense of self. Without narcissism, we would all die. It's not a bad thing being narcissistic. When we talk about narcissistic personality disorder, what we mean that there are some people whose ways of trying to cultivate a positive sense of self makes them come off as haughty or arrogant or dismissive of others or very self-centered. But it's not that it's narcissism, it's that it's sort of an obnoxious haughtiness. But self-psychology would not call that narcissism. It would call many, many things narcissism, and not in a critical or pejorative way. relationships, events, and activities are meaningful to us insofar as they impact the way we view ourselves as lovable, loved, effective, significant, capable, attractive, etc. These are the ways that we want to see ourselves. Mirroring is an important concept in this approach. Mirroring is the type of feedback that children, when all things are going well, young children get from their parents. I try to avoid doing this because it's such a cliche, but I can't help talking about my young children when I illustrate psychodynamic theories. I have a young daughter. She's now 6. I'm going to have to stop telling the story because it's going to get embarrassing to her soon. But when she was about 3 years old, she would tend, like before her bath, she was getting undressed, she would take off all of her clothes and run downstairs and run around dancing naked and say, "Look at me, I have a tushy, woo, woo, woo." And she loved us, she loved to sort of run around naked and have everyone look at her body. That's a normal experience for a young child, actually. And to take delight in your young child's body or cuteness or things like that, to just enjoy, sort of directly enjoy your young child's presence, laugh at them, giggle with them, hug and kiss them, that they see that you take a lot of pleasure in their presence. According to this theory, that is a vital experience that children have in life, and it makes people feel lovable, attractive, enjoyable. It gives them a tremendous sense that people enjoy me, people are interested in what I have to offer, people like to be around me, they are interested in my thoughts. Now, as she gets older, she's no longer running around naked and doing that, but she likes to tell jokes. Jokes are a big deal in my family, so she likes to tell jokes and have people laugh at her jokes. She likes to draw things and have people look at her artwork. These are all examples of mirroring, would be when her parents or other important people to her really take a lot of pleasure in these aspects of who she is. Idealization is another very important type of relationship according to this theory, which is a more advanced state of maturity, where people need role models to look up to. And role models give us values, they give us ambition, they are a model for what's possible in life or what's admirable in life. So having heroes, having mentors, having idols to look up to, having pictures on your wall of, in some of our communities it's Rebbes and great Talmidei Chachamim. In other communities in America, it would be athletes or rock stars or actors and actresses. But it's important to have role models to look up to. It's part of what pulls us forward in life. So Roberta, here's an example to see this in the Transference. Roberta finds that it's extremely meaningful and important that I understand how she actually feels, that I don't impose on her a preconceived notion of how she ought to feel. That was a very important aspect of our treatment, that she realized that I actually didn't have a strong stand on what I thought was right for her to do in her dilemma, but I just thought it was extremely important to understand what are the consequences for her. A dilemma is when you have two bad options. Both options are painful for her. And doing nothing, which is what she was doing, was also painful. So for me to try to understand the position she was in, that was an extremely important experience for her to have in the therapy and was, I think, central to her getting better. She would say that as well. Roberta senses that I find my professional work to be deeply gratifying, and she admires the fact that I've been able to find my professional calling. That's something that she revealed to me during therapy. She thought, this is really, I see that you have found the career that suits you. That's something that she shared with me. Now, was that really based on, yes, I'd like to think it was based on her accurate knowledge of what a wonderful therapist I am, but in terms of seeing this as transference, this was based on the fact that she now has the notion that someone can, find what they're good at or what they enjoy to do or what's a good outlet for them and make that person's career. That's like a new model for how to live that she was able to get out of therapy. So according to self-psychology, the therapist sort of functions as a new type of person. It's a new type of relationship. There are healing aspects of that relationship that help maturation get on track. The final approach to analysis that we'll talk about is what's called intersubjectivity or relational analysis. Intersubjectivity is a big mouthful, but By the way, I was reading a book on intersubjectivity. It took me a long time to get through this book. That same 6-year-old daughter, when she was 4, saw me reading this book, so she said that was her favorite book. Her favorite book was Intersubjectivity. That was her favorite book. So this is a specialized version of object relations theories. This approach would posit that the fundamental motivation is to be in intimate relationships, but it pays much more detailed attention to the analyst or therapist's emotional contribution to the therapeutic relationship. It views the emotional connection between the analyst and the therapist and the patient as unique. Every pair is going to be unique because it's a confluence of 2 unique personalities in the room at the same time. Unlike more classical views where the transference is sort of the patient's shtick that the patient will bring with him or her to sort of any therapeutic relationship. So we would predict, according to classical theory, that the patient will feel more or less the same about most therapists. This patient has a very, very aloof and judgmental father, and she got through life. She negotiated that relationship by trying very hard to please him, by pursuing interests that were similar to his. So she'll probably do something like that with pretty much any therapist. That would be a classical view. Calling in 1 second. That would be a classical view of the transference. An intersubjective view or relational view would be no. There are plenty of unique things about my own personality that I bring to every therapeutic relationship that will shape how the transference comes out. And there will not be a similar therapy that she could have from one person or another. It'll be a unique transference and a unique emotional relationship. Whoever that therapist is, that person's unique personality will have a profound impact on the therapy. So we start to look at transference differently according to this theory. This is a more contemporary theory. The transference is co-constructed or co-created between the therapist and the patient. You had something to say. Well, I'm not talking yet about countertransference. The question is, what's the difference between this and normal countertransference? I'm actually not talking about countertransference at the moment. I'm talking about transference, the patient's emotional valence toward the therapist, how the patient feels about the therapist, how the therapy work stirs things up in the patient. That this theory does not state that the patient's sort of earlier life and setup for personality is going to be highly predictive of exactly how the transference will unfold. The way cases used to be formulated is we would say, what are the transferences that we predict will probably unfold in this treatment? That would be a very typical question of someone trying to present a case for analytic treatment in an analytic training program. What is the patient's transference readiness? What transferences do you predict or anticipate will unfold in the treatment? An intersubjective analyst would not ask such a question, actually. That would be considered an illegitimate question. We will have to see how the relationship unfolds, and the therapist is responsible to see his or her contribution to how that's shaped. You might have thought that was a given, but it wasn't a given until people were dissatisfied with the earlier theory. That's why this theory was developed. Okay, so the emotional connection between the analyst and the therapist is unique. It's determined by both the patient's and the therapist's unconscious. In other words, it's not solely the patient's psychopathology or fantasies that determine how the relationship unfolds. There's a much more flexible stance toward disclosure, according to this theory. Non-disclosure, being a blank slate, not answering questions, that was really a technique. You know, people saw that as like this inviolable rule. Mostly people who got just sort of bad supervision or bad training. They just sort of had the notion that you're just not allowed to answer questions to your patient about yourself personally. But the reason for that technique was because if I see myself as largely a blank slate upon which the patient is going to project his or her fantasies, I don't want to contaminate that with any of my reality from my life. So what I'm going to do is I'm going to leave it as clean as possible so we have a nice white screen without lots of bumps or smudges on it, and I can see exactly what the patient's projecting onto me as a screen. This therapy would say that that's really sort of a futile exercise, the relationship isn't equal. It's not a symmetrical relationship. It's hopefully more about the patient than about me, because the patient is paying me for my professional time to help him or her. But I have many aspects of my personality that are certainly present in the room and shape how the patient opens up to me. It sees enactments. Enactments are ways that the patient's personality will, and my personality will sort of come together and cause certain things to happen as inevitable, and there's something to be understood. They're not a technical error to be avoided. So, for example, I have a patient who comes at a certain time in the morning when I'm always making my coffee. That patient, I give that patient coffee every, morning that she comes to treatment. I don't do that for any other patients. It is something that I have to think about. It is a violation of my usual stance. It probably has an impact on the treatment in some way. There are probably things about me and about that patient that are stirred up that cause me to make nice coffee for this patient that time of day. But I don't think that some horrible thing has happened and the world has ended and I can't proceed with treatment in some way, that I've violated some rule. And I don't think that it is like irrevocably shaped the way treatment is going to unfold. I have to understand, why did I do this? What was happening inside of her and inside of me? And what does that say about her and about the two of us? But it's not, it is something that happens between people who meet with one another and have strong feelings about one another and are conducting professional work. Feelings develop for one another and things do happen. It's not a boundary violation, but it is a different boundary than with my other patients who at that time of day I don't make coffee for. And why is that? I have to think about that. It could be another talk. I'm not going to get into it. And I will not entertain any speculation from the audience about why I do that. Here's another true example. This is about Roberta. This is true. My mother, when I was a young child, went back to graduate school to get a PhD in Russian literature. She became significantly depressed, and she attributed this to the fact that she was pursuing this PhD just to prove a point. She said, I went to get a PhD just to prove a point. And she, in fact, had no wish for an academic career at all, my mother. She wasn't planning to become a professor. She just wanted to prove she could do it. And she got very depressed in the process of doing this. And I don't think about this at all during the treatment with Roberta. I mean, this does not come onto my mind in any way whatsoever. And this has such a strong parallel with my own mother and absolutely did shape a lot of feelings that I had about her, which was coming from me. Another thing which is true is Roberta bears a very uncanny resemblance to my mother as a young woman. I mean, it's an eerie resemblance to my mother as a young woman that I did not recognize till very late in the treatment of her. These would be examples of the confluence of the two of us. This is sort of my shtick from my history, and the idea of seeing a woman who is trying to pursue an ambitious academic degree that she really doesn't want to, and suffering as a result of doing it. That stirred a lot of things up in me, which were not based on her psychopathology or her relationship history. That was based on my personal history, my relationships with my mother. And then I, at one time, said to my therapist at the time, I was just so upset. I mean, it's as though I've pursued this entire treatment just trying to save my mother from my mother's problems. And my therapist at the time said, well, why do you think any of us go into therapy? That's what he said to me. So, a little bit about countertransference. We're not bad on time. Countertransference. So countertransference, the basics, the countertransference, it's the therapist's transference back to the patient and the therapist's transference back to the patient's transference. The classical view was that it was strictly to the patient's transference. In other words, if a patient develops an erotic transference to the therapist, if a patient has sexual attraction to the therapist or tries to seduce the therapist may feel angry at an assault on his or her professionalism. That would be an emotional response to the transference. or the therapist may feel very flattered or sexually aroused. That would be a response to the transference. Another example, the patient is extremely deferential and obsequious to the therapist. That means like nice in an unrealistic manner, flattering in an unrealistic manner. Very, very deferential, complimenting, constantly being super complimentary of the therapist. The therapist feels like this affection or flattery is saccharine. I mean, it doesn't feel genuine. It feels phony and feels like it's contrived, and starts to wonder if it's hiding an underlying hostility. And the therapist feels disappointed that the patient sort of has a lack of basic trust, or there's a deficit in the patient's openness, doesn't really trust the therapist's positive regard for the patient, feels that she or he has to be so deferential to me, so complimentary to me in order for me to like her. It irritates me. Why can't this patient be more realistic with me? That would be my emotional response to the transference. Are we all together? Okay. It's easy to see with Roberta how it resembled the relationship with her father. Her father was a very touchy man. She experienced her father as a prima donna. She was able to say that sort of later in therapy, and felt that she had to be constantly very admiring of his academic and intellectual accomplishments. That was easy to do because he had very great many of them. Some contemporary revisions of the countertransference is that the therapist has a real personality, a real sense of humor, real issues that provoke irritation, like not laughing at my jokes. The therapist may be reacting to feelings that the patient has toward him or her, which are based in reality, that should say. An example, patient has regressed into a very severe depression, which requires the therapist and me to be available outside of office hours. Okay, so this is a different patient, a very, very severe depressive episode. It was provoked actually by a patient's inability to conceive, infertility issues, and probably some infertility treatments that were bad for her mood. The patient is extremely grateful that the therapist has become more flexible with certain frame issues. My email, my cell phone, phone calls after hours, wanting to schedule, I want to hear from you this weekend. I want to hear if you're getting better yet. Just a lot of contact outside of the regular treatment sessions, which wasn't the typical way, but I just felt it was absolutely necessary. It was such a severe depressive episode, and I really needed to know if she was getting better and make sure she wasn't getting worse. So after this is over, the patient buys a gift for the therapist with a card signifying this gratitude. So the patient is bringing a gift to me. So should the therapist try to understand a deeper hidden message in this gift? Should that therapist decline the gift or put the gift on hold or accept the gift, but try to understand if there's does this patient feel a need to buy someone's affection? Does this patient feel guilty about having care provided for her? What's the proper technical stance? You could formulate it in that way, that this patient feels unentitled to my concern for her and feels the need to pay me back in some way because she's afraid that I'll grow tired of her or resent her. You could formulate it. There might be some truth to that. But is that a correct stance? Yes.
No, I don't think it's a correct stance at all. I think it's insulting and demeaning to not be able to understand that in our world, when people do something nice for somebody else, there are real ways in which we relate. And if you've gone out of your way to do something for her and she appreciated it, I think it's dismissive of her to simply interpret it as she's the patient, and there must be some deeper, darker meaning, and that you can't accept it.
Right. So for the tape, the response was that it would be a very bad or wrong interpretation to try to interpret this as a sign of psychopathology and not accept a genuine gratitude toward my real availability to her, which she knew was above and beyond what I normally do, which she knows from her work with me. And I totally agree with that. That would be a more contemporary, flexible view of transference and countertransference. It would actually be a problem. It would be my discomfort with her gratitude if I have to do that. That's actually what would be happening if I responded that way to her gift. Yes, Nala?
Doesn't it depend on what the gift is? I mean, I think, a $50 gift or a $25 gift is different than a $500 gift.
Yes, it does depend on what the gift is.
I was going to
Depends on what the gift is. Yes, or aside from the amount of money the gift is worth, we could think of a lot of other gifts that we need to decline.
Could you say that the fact that you're willing to give her extra time is really just still part of your therapeutic responsibility with her? And therefore, why should it ever get past a therapeutic relationship? And therefore, maybe the gift should be declined.
Well, if I understand what you said, is that could we just say that that was just part of my professionalism and judgment as a clinician, that she needed extra time, and therefore I could decline the gift because you don't owe me a gift. This is just, I'm just doing what's necessary to be your doctor, and you pay me for my professional time, and that's all your obligation is to me. Is that your comment?
Therefore, it would be a transferential issue between the gift would take on more than just the gift.
Well, she felt it was beyond, I don't know if she felt it was beyond the call of duty. I think she felt it was truly living up to the call of duty, and she was grateful that I recognized it was living up to the call of duty. I guess that I do accept that a therapist acting in his or her professional capacity consistently and compassionately and empathically does engender more than a simple satisfaction for professional services in the patient. And this is, this is what Sigmund Freud called the benign unobjectional transference, but that is a mouthful. But what that means is that when we open ourselves up and listen closely to patients and pay, deep attention with careful concern for what they're feeling inside and try to help them understand it in a way that will not hurt them more, and we realize that they've been hurt a lot in life, and treat them delicately and go through that with them, I think that it does create a very special bond, which is different than other professional relationships. So I guess I just feel differently about it than what you're saying. I accept the gift as a mature and not problematic expression of her gratitude for me helping her. That's kind of how I see it. But I hear your point. You could see it that way. Yes?
Number one, I think it's a judgment call. And I'm not sure it has to be one or the other. I think it could be accepted graciously. And at the point that the therapist can judge whether he thinks there should be something said about whatever hidden message might, or hidden, not message, but feeling that this particular patient might feel guilty at having taken so much time or whatever. I don't think it's uncalled for, depending on the situation. After you've accepted it and it's fine, it's good.
Right. So I'm going to change the comment a little to just put in a point I wanted to make, which is that sometimes accepting the gift, it'll be much easier to discuss what the feelings are that, you're worried. Were you worried that I would be irritated with you? Were you worried about the amount of time that you took up? Sometimes accepting the gift would make that actually an easier discussion than not accepting the gift. I'm going to move on. Patient sees that the therapist is very interested in hearing dreams and takes copious notes when dreams are related and exerts greater effort in interpreting them. The patient starts remembering more dreams and writes them down. So that's the response. The patient notices that I listen to dreams. I take notes in a different way during dreams. I'm very interested in a lot of the symbols of the dreams. I ask for associations to the dreams in a more detailed way than I do to other material in the session. And what do you know? My patients they behave well and they dream for me. And some of them get journals and start to write down their dreams. I don't even need to tell them to do that. What is the significance of that? What does that mean? They might wish to please me. They might be very, very taken with the experience of having the dream listened to closely and like it and want to do that more. They may just see that there's a lot of progress which is being made with dreams, so they wish to continue progress. It's probably a mixture of a number of things, but we don't really believe that we can separate it all out. I mean, it's all happening simultaneously, and there's a way of interpreting something to death, and we don't want to interpret things to death, especially things that are good and are working in the treatment. So this would be another example where I think if someone would start to point out, gee, I noticed that you never used to take notes and dream very little, and now that I like to interpret your dreams, you're dreaming all the time and taking notes. That would be, no one would ever say it that way, but that would be my discomfort. That would be my countertransferential issue, that I am somehow uncomfortable with my impact on the patient. The patient is changing in response to me, that somehow bothers me. I'm maybe so gratified by the influence I have or by the patient's response to therapy that I will feel defensive or nervous about it. That would be, I think, to interpret that would be probably the therapist's countertransference issue in some way. A little bit more about the contemporary revisions. Projective identification, that's a classical defense that was described first by Melanie Klein, actually, which was about when the patient induces his or her disavowed feelings and wishes in the therapist, not projecting them on the therapist, but making the therapist feel that way. An example would be a patient with a long history of feeling victimized, helpless, and abandoned by caretakers. This is the patient's history. The patient is extremely resistant to the therapist's suggestions. The therapist feels frustrated and unable to help the patient and feels that the patient is uninterested in what he or she has to offer. The therapist starts to feel helpless. The one way to understand that would be that this patient copes with feeling helpless and powerless by making others feel helpless and powerless. That's a way that the patient protects him or herself from feeling helpless and powerless. A contemporary view would be the following. The therapist's narcissism and wish for power over others are related to his or her choice of a career and style of interactions with patients. I mean, let's face it, we are in this field because it makes us feel certain ways about ourselves, and we're gratified by our interactions with our patients. When a patient is not collaborative or is skeptical of our perspective, how do we feel? We feel narcissistic injury. We feel an assault on our authority or power. That is something that we feel in response to patients. So to call it projective, the contemporary view would be the idea that we're going to call it projective identification as though like my feelings were not part of this interaction in any way. It's just a very unrealistic way. I'm taking my own feelings out of the equation in a very unrealistic and unfair way. That would be a contemporary revision of projective identification. Just get to clinical use of the transference a little bit, and countertransference. If you remember back to that initial cartoon, for those of you that walked in late, there was a cartoon that showed a patient on the couch complaining about how boring his life is, and he says, I have not met anyone interesting in years. And the therapist is thinking, what am I, chopped liver? It's a personality biopsy. That's the way to think about your countertransference. If you meet someone, you have an initial impression about them. Or in your interaction with someone, you start to feel a certain way that they're treating you. It's like taking a little biopsy or sample of the person's personality. That's how I would like to think about countertransference. This is a recent case. An adolescent boy, his presenting symptom is really his parents' symptom. They bring him into treatment because he's so perfectionistic that he can't get anything done. He takes forever to get ready in the morning, and his parents can't get him out of the house on time. I mean, brushing his teeth over and over again, worried about clothing being wrinkled, worried about his shoes being tied perfect. I mean, just everything takes forever with him, and they can't get him out the door. During the session, I should say during the first session with him, I'm feeling frustrated, and I'm looking at the clock, and I'm sort of wishing the session away. And I realize, I'm really constantly looking at the clock and wishing the session would end, and I'm not sure why I feel this way. So I try to pay attention to what's happening, and I realize that this is what's going on. well, I'll read it and then I'll explain what it means. I realize the patient pauses when he's done answering a new question, and as soon as I answer the next question, he starts embellishing his answer to the previous question. So, for example, I say, tell me about some of your hobbies. And he'll say, well, I like to do Sudoku puzzles. I like to play video games. And then there's a pause. And I go on to the next question, and I say, what's school like? And as I start to say, what is school like for you? He says, and also, I like to watch baseball and pay attention to statistics. And then he pauses again, and I'll try to ask my next question. And he interrupts me, and he says, and I'm thinking of starting a fantasy baseball league. And this goes on and on. I cannot get to the next question. He pauses, sort of signifying for me to answer the next question, but then he goes into the next. He gives more information, so I just can't move on. And it's a very, very frustrating experience. He's very new, so I don't have rapport with him yet that I feel able to address it. And I don't even exactly notice what's happening. I just feel very irritated and frustrated as this is happening. I feel like the patient is thwarting my efforts to interview him. I have a fantasy that he's deliberately torturing me. That's actually my fantasy, is this kid is waiting for me to ask the next question. He's like, aha, and what I'm also thinking of doing is I'm thinking of starting an art project. And I can't move on. So I start to feel like he's tormenting me. He's torturing me. This is my countertransference, okay? This is how I feel. It's really my countertransference when I'm up here. I'm frustrated and irritated. I'm looking at the clock. That's already my countertransference. I'm not sure about why. I start to think about what's happening. This is what I realize. I have this fantasy. That fantasy was already inside me, but the fantasy becomes more conscious. That's my countertransference. I have a new hypothesis about what's happening between him and his parents. My hypothesis is that he's using perfectionism as a means to defy his parents, who he feels are attempting to control every aspect of his life. That is my hypothesis now about this new patient. That hypothesis comes from my fantasy that he's torturing me, which comes from noticing that I'm irritated by him. That's what it's like, a personality biopsy. That's how I try to use the countertransference. And I believe that he is doing that to me. This is a relatively new case. I don't have a lot of, but this is my hypothesis. I believe that that is his transference. That's an early transference to me as an authority figure, that he is not going to make it easy for me to do what I wish to do with him. Okay, we are going to take a break. We're close to halfway through. We'll start again I need 4 volunteers. 1, 2, 3, 4. Okay, got 4 volunteers. Volunteers, please come to me during the break now, and then we'll get started at 10:30 with the workshop.
I have patience. I do, but it involves meds, so if that
Involves
bothers you,
meds?
then...
Do you have a patient, or you want to be a therapist? Or you're flexible?
I'd rather be a patient.
You have a patient in mind too? The patient in mind, or you want to be a therapist? Patient.
Everybody wants
Okay.
to know who wants to be
So
a
let me
therapist.
just hear a thumbnail sketch, and let me choose what I feel like I can easily work with. Thumbnail sketch your patient.
I have a patient who's on long-standing benzos, all sorts of problems with her mom, really bad life, lots of abuse, became lesbian late in life after using drugs and getting sober, blah, blah, blah. Who comes to me, Dr. Schreiber, please, I'll go down on my Seroquel, but you have to give me more Klafter. And comes irate and screaming at me, telling me I love her, I never do anything for her. It's just very heated.
Okay. Thumbnail sketch your patient.
Constantly flirting. Married is a CEO. Cannot stop.
Male patient. He can't stop flirting with women. Okay.
Completely aware of what he's doing, explains that he has a hole in his arm, goes back to his childhood, about his parents, and was always driven to achieve. And
Does he stir things up in you during the appointments?
oh yeah,
Irritation or anger or
no sympathy.
sympathy for him? Sympathy for him. Okay. Okay, that's interesting. Thumbnail sketch of your patient. You have a patient?
Yes.
Thumbnail sketch of your patient. Right, of course. Everyone. Yeah. Let me hear a thumbnail sketch of your patient. just got you your patient?
Guy in his mid-60s, has a lot of physical problems, very tall gentleman. His father died when he was 9 years old and said he was such a miserable drunk it was better that he was dead. Got caught going to meet a fictitious 14-year-old girl to have sex with her. Now he's awaiting everything. He just got arrested. He's actually hasn't been formally charged yet or sentenced.
Okay. So, all right. So I have to make an executive decision. Patient, therapist, patient, therapist.
Oh, God, okay.
So he'll be my therapist.
He'll be your therapist. Right.
Oh, poor
And you'll be her therapist. You'll give a brief synopsis, and then you'll start to portray a session. She'll portray a therapist. She'll be the therapist speaking to your patient. You're portraying your patient. You don't have to pick a topic. You have to just give a vignette, as you did to me, to the group, and you'll try to. You'll see. It'll come to you.
Okay, I'm gonna learn something out of this, right? If you're making me a therapist, right? I'm gonna
Yes.
learn something. Okay, good.
Yes.
And what am I an intersubjective analytic guy here, or what?
You're just being yourself. You're just being yourself.
Okay.
You're just being you.
See, I'm not an analyst
Just
at all.
being you. No, you're just being you.
Are you an analyst, by the way? No, I'm like,
We're
I'm
gonna
not
go.
an analyst.
No, we're gonna go.
Okay, can I grow coffee?
Yeah, go ahead. We're gonna go. Probably. So we're gonna have an hour and a half. So we'll go probably. I mean, I'm gonna be interrupting a lot, but it'll probably be a half hour each, and then a half hour wrap up at the end.
How
That's what we'll try to do.
therapy am I with it? The beginning, it's already after time.
Whatever you wish to portray. Whatever you wish to portray. You can't really. I mean, you can't really avoid portraying where it is now, because you're portraying your patient as you know him now. You know, and you're not a professional actor with a script to do it. So you'll just.
I was a professional actor.
Oh, okay. Well, that's okay. Well, most people can't do that.
So yeah.
This is my workshop format frequently. So you know, it usually works, and people are able to portray their patients pretty well, actually. Hi, nice to see you again.
I wanted to ask you, why can't the first example of countertransference you gave
Yeah.
with the dreams, that was in the second actually, right?
Yes.
So then the client noticed that you like it and therefore doing more of it, right?
Right.
Why can't you just say that the client actually felt that they get something out of the interpretation that you are offering or whatever giving you offering?
They want more of that.
And they want more of it because they like it. Why does it be something that's different for you?
Well, you could say that, and that's probably consciously what's on the patient's mind, and that's why I wouldn't want to interpret it. But I think it probably is more than. I mean, I think if people actually dream more and remember more of their dreams.
But you all dream more than you remember. You just remember.
Yeah, but if you remember your dreams more, I think there's more. I think there's more unconscious impact than what you're saying. I don't think it's just a decision to bring more dream material and write them down. I think that there's something happening in the person's mind, and it's stimulated by this. It's stimulated by the relationship with the therapist. I mean, it's like something is opening up inside of them, and it's sort of like coaching. It's like, you know, when you have if you have kids that play sports and there's a really good coach, they love the coach and they want to play for the coach, and it has an impact on their physical strength and their speed, which is not just technical. So I think there's more, and I think that is transference.
And then why I'm asking that, because I remember 25 years ago, I became your manager. I was training in London University. We had one.
So I realized you look like someone else I know. I said nice to see you again. We've never met before. I'm Nuffin Klafter. What's your name? Ruthie Knopf. Okay.
Okay, so I was trained at London University, and I remember we had a course on dream interpretation.
Right.
And
Just come with me. I'm going to get chairs. Yeah. Right.
And then when it was a phase, and I'm back to the same level. I really don't remember what I did, unless it's something whatever, right?
Right.
So I think that it's something that's really induced by you yourself. I mean, you have so much interest to do so, and it doesn't really make a difference right. You could see it's something that's part of countertransference, but if I don't think that they will do it to please you if they don't get any benefit out of this at all, just to please you. That's kind of, I'm not sure.
Okay, well, I hear, I mean, that example is an interesting point. I mean, that's still how I see it, but you're giving evidence of something else. But I would wonder about, no, I don't know. I think it's complicated. I think there are many, I think it's multi-determined. So the transference is one of the layers.
Absolutely.
That's what I think.